Hi everyone. Today we're going to talk about the basics of reading an EKG. This is the very bare minimum basics for nursing school and is not intended to give a well-rounded review of how to read an EKG for more advanced cardiac rhythms. When we look at an EKG strip, it's important to know what the different time frames are for the different designations within the strip. To start off at the smallest size, we have our very tiny little box. Each tiny little box represents 0.04 seconds. So 5 of these, or one larger box, is about 0.2 seconds. 3 of these boxes would be 1 second, and from tick mark to tick mark is 3 seconds. So when we're measuring an EKG strip, we usually look at it for 6 seconds at a time. So we're analyzing from 1 tick mark to 2 tick marks later for that 6-second time frame. And this will come into play a little bit more when we talk about finding the rate and rhythm. In reading EKGs, it's important to also understand the waveform. So the first thing that we have here is the P wave. There should be one P wave for every QRS. So this is our QRS segment. And then we have our T wave as well. So when we're looking at our EKG, we're looking for a couple of things. Do we have one P wave for every QRS? Is our PR interval, so the start of P to R, less than 0.2 seconds? Is our Q to our S, or our QRS complex, less than 0.12 seconds? Is our QT interval, so from the start of Q to the end of T, is that less than 0.4 seconds? We look at our ST segment, which is this line right here, and we're looking to see if that's isoelectric or if it's elevated or depressed. We're also looking at the T wave to make sure it's upright and rounded, and we're making sure that there's no U wave. And on this next slide here, you can see what that U wave is. So it comes right after the T wave, and typically it's not something that we see. If we do see a U wave, it generally means that there's some type of electrolyte imbalance. So now the next step of understanding EKGs is understanding what each of these segments of the waveform represents. So as a refresher, the electrical conduction of the heart starts with the SA node. The SA node fires a signal that travels down to the AV node. As it travels down to the AV node, it causes atrial contraction. Then the AV node sends the signal down the bundle of His to our right and left bundle branches and to each of these little Purkinje fibers. As the signal transfers from the AV node down through the rest of the heart, it causes ventricular contraction. So we can look at the waveform and see what part of the wave we're looking at to understand, does the problem originate with the SA node? If so, then we have an atrial complication. Does it originate with the AV node? If so, then we have ventricle problems. So the P wave is the firing of this SA node, or atrial depolarization. So the P wave represents that atrium contracting. The QRS complex is this AV node sending the signal. So it represents ventricular depolarization. But at the same time, we know that as the ventricles contract, our atrium relax. So that's why the QRS complex is so large, because we're in this part of the waveform, we're seeing both the ventricles contracting as well as the atrium relaxing. And then the T wave is the repolarization of the ventricles, or the relaxation of the ventricles. So now on to the steps of reading a rhythm strip. So the first thing we want to look at is the rhythm regular, irregular, or regularly irregular, which means that it's irregular, but the irregularity has a pattern to it. After we determine that, we look at what is the rate. Then we look at, is there one P wave for every QRS complex? What is the PR interval? Then we measure the QRS interval. Then we measure the QT interval. Then we look at the ST segment to see if it's elevated or isoelectric. Then we look at the T wave to see if it's upright and rounded. And then we look for any extra waves like that U wave. So starting with the rhythm, as I mentioned, we want to look for that 6-second strip. So it's going to be 2 tick marks away from where you're measuring. When we get the rhythm, we want to see and count how many full waveforms we have within those tick marks. So on this one, we would have 1, 2, 3, 4, and we're not counting this one because it's not the whole waveform within that tick mark. So this heart rate would be about 40 beats per minute, which we do know is bradycardia. This technique only works if the rhythm is regular. If it's irregular, then there's another method that you have to use to get the heart rate. When we look at the rhythm, we can designate it as bradycardia, which is between 40 and 60 beats per minute, a normal rhythm, which would be between 60 and 100, or tachycardia, which is greater than 100 beats per minute. Next, we look at the P wave. We want to look, as I said, to make sure that there's one P wave for every QRS complex. There's 2 abnormalities when we have multiple P waves. And what that represents is that the atrium are contracting and the SA node is firing too quickly and more often than your AV node. So the 2 types of atrial rhythms that we have is atrial fibrillation, and that's when our P waves are kind of indistinguishable and you can't really tell how many there are. It's more like a squiggly line where that P wave should be. The other form is atrial flutter, and this is when the P waves look like a sawtooth formation. It's this shape as well as very repetitive. Both of these are very concerning rhythms that require treatment. It can require cardioversion, it can require arrhythmia medications. We're also going to be thinking about things like atrial fibrillation because that atrium is beating so quickly, it's actually just quivering and it's not having good contractions. So it's not having good blood flow to the ventricles. So there's increased risk of clots. So these individuals will also be having blood thinners as well. So these are both 2 rhythms that we do not want to see when we're looking at the P wave. Next, we look at the PR interval. As I said, normal is less than 0.2 seconds or 5 of the little boxes. So 1 box that size. When the PR interval is longer than 0.2 seconds, then we have a heart block. A first-degree heart block is when that PR interval is greater than 0.2 seconds. There's 2 types of second-degree heart blocks. Second-degree heart block type 1 is when you have a predictable but increasing PR interval. So one might be 0.22 seconds, the next one might be 0.24 seconds, and then 0.28 seconds, and then it resets back to 0.22, then 0.24, then 0.28, back to 0.22. So it's a repetitive increasing pattern. A second-degree heart block type 2 is when you kind of have that increasing pattern as well, but you're having a missed beat or a dropped beat. So you're going to have a portion of the strip where the PR intervals are consistent, but you're missing a QRS complex and you have that extra P wave in there. And then a third-degree heart block is when the PR interval is just inconsistent across the board. Then we look at our QRS complex. A normal QRS complex is less than 0.12 seconds. When it's greater than 0.12 seconds, we have a bundle branch block, and it causes your QRS complex to have this funky look to it. There is a way to tell if it's a right bundle branch block or a left bundle branch block, but that's more advanced cardiology, so we won't talk about that in this video. Then we look at the ST segment. As I mentioned, isometric is normal. So this would be isometric where it's even with the rest of the strip. We can also have ST elevation, where that ST segment isn't down here where it's supposed to be, but it's actually higher up and goes right into that T wave. Typically, if we have an elevated ST segment, it means that there's some type of ischemia, increased intracranial pressure, or early repolarization of those ventricles. And then moving on to our QT interval. A normal QT interval is less than 0.4 seconds. And you can see that what that measurement would look like here in this top waveform. You start at the Q, end at the T, and so this whole time frame would be less than 0.4 seconds. An abnormal QT interval is when it's prolonged. So you can see here we have the start of the Q. This would be 0.4 seconds, but the T wave actually goes beyond it. So everything in the red here is that extended QT prolongation. The QT can become prolonged if there's an electrolyte imbalance or dehydration. It's commonly a side effect of medications, especially antibiotics and psychotropic medications. It could be a sign of hypothyroidism. It can also be caused by a stroke or history of heart disease. Having a QT prolongation can cause seizures, heart palpitations, fainting, and death. So it is something that we look at and take seriously. Then we have our T wave. As I mentioned, a normal T wave is upright and rounded. Some abnormal T waves could be a pointed T wave, which would look like this strip here on the left. And a pointed T wave can mean hyperkalemia, or it can be a very early sign of a STEMI. And then an inverted T wave is when the T wave is upside down, as you can see in this right strip. And that could be an indication of a myocardial infarction, a pulmonary embolism, or damage to the heart. Then moving on to our ventricular rhythms. So these are rhythms where the ventricles are not depolarizing and repolarizing properly. The two types of rhythms that we have is ventricular tachycardia, or VTAC, and this is when you see no P waves and no T waves. You just see abnormal but repetitive QRS complexes. It is a very fast rhythm. Then ventricular fibrillation is you have no discernible P waves, QRS waves, or T waves, and no discernible patterns. It's just a bunch of squiggly lines. Both VTAC and VFib are very serious rhythms and often require defibrillation. Torsades de pointe is a type of VTAC in which you see more of a twisting waveform. This can be caused by QT prolongation and other medications, and it may spontaneously resolve or it can progress to VFib and cardiac arrest. Another type of rhythm that we can see are junctional rhythms. This is when the rhythm comes from the AV node and starts in that AV node instead of the SA node or the bundle of His. In these junctional rhythms, you often don't see a P wave, or that P wave may be inverted, as in this strip right here. There's typically an abnormal QRS in a junctional rhythm, and the rate is often less than 40 beats per minute, but it can be accelerated or tachyjunctional rhythms, which would be more consistent with what you would see in tachycardia and a normal heart rate. And then the last type of EKG things we can see are flat lines. There's two different types. One is a sinus pause, and that's when everything is measuring normal, except you have a period of time where there's a flat line. So we would measure that as normal sinus rhythm with a however many second pause. So in this case, it would be normal sinus rhythm with about a 2-second pause, because there were 2 seconds when the heart wasn't beating. The other form of a flat line is asystole, and that's when we have no cardiac activity. As you can see here, it can be a pretty flat line, or it can kind of have a little bit of a wave and squiggle to it, but there's no heartbeats within that rhythm. The last thing that I just want to say is if all of our measurements are accurate, so our P wave, there's one P wave for every QRS, our PR interval is normal, our QRS is normal, our QT is normal, our ST segment is normal, and everything looks normal, that's when we call it sinus rhythm. If the heartbeat is a little bit less than normal, but all the measurements are the same, that's sinus bradycardia. And if it's a little fast, but all the measurements are normal, that's sinus tachycardia. And that is a very quick overview. of interpreting an EKG.